Hi everyone, and welcome to the new activities of the PhenoLab. This evening, it's my pleasure to begin our seminar with Professor Guilherme Messas. Professor Messas is a psychiatrist graduated by the Faculty of Medicine of the University of São Paulo in Brazil. He holds a MSH and PhD from the same institution. Professor Messas teaches at the Santa Casa de São Paulo School of Medical Sciences, and is member of the management team, international lead for Brazil of the Collaborative Center of Values-Based Center at St. Catherine's College at the University of Oxford, where he is also leader of the International Meta Master Program. He is author of several books and scientific articles dedicated to examining the use of phenomenological method in psychiatry, including the existential structure of substance misuse, a psychopathological study published by Springer in 2021, and also the three dialectics of disorder, refocusing phenomenology for the 21st century, co-authored with Professor Bill Fulford. Professor Messas has been working as a psychiatrist for the last 30 years, attending clinical cases in his office in the city of São Paulo, using phenomenology as a method. He is coordinator of two 400 hours master courses, the phenomenological psychopathology at the Santa Casa de São Paulo School of Medical Sciences, and the phenomenological psychiatry at the Paulista Faculty of Health Sciences. He also participates in national and international research projects related to psychiatry, psychopathology, and public policies on alcohol and drugs. Guilherme, thank you very much for accepting my invitation, and the floor is yours.
Thank you very much, Francesca. It's been a honor for me and a pleasure to be part of this very exciting initiative, the PhenoLab. It's been trying to develop and widening the influence of phenomenology around the world. And personally, it's an honor for me. And hi, everyone. Very good to meet you, though most of you can see only as a name in my black screen. But anyway, we can try out somewhere with a hi. And hope we can interact after my presentation. The idea here, let me try to share some slides only to guide my ideas. Well, yeah. My intention here is in the next 40 minutes or so is to develop a particular conception of phenomenological psychopathology that is, as far as I understand and as I will try to defend in the following, can be a leading perspective for actually renewing the participation of phenomenology as a strategy for clinical mental health care. Of course, I could also say that phenomenology can be extended not only for clinical care, but also to other fields like, say, public policy and researches as well. But my intention here is a more limited one, only to talk about phenomenology in clinical mental health care. To do so, I have some summary. I'd like to present to you some summary of my presentation. The idea is, first of all, presenting the context of this title. In other words, the context of this need of this opportunity for phenomenology in mental health in the big picture of mental health in contemporary times. After that, sort of linking to that, I will present some historical perspective. My interpretation, as you will see, is that we can only understand the role of phenomenology in psychopathology and in mental health as a whole if you are able to have a historical perspective. Only by having this, we can not only understand the success and limits of phenomenology in past time, but mostly to understand this role for phenomenology currently. After that, this historical perspective, and as a consequence of what I will put forward, I will present the core of this presentation, which is the notion of dialectical phenomenology. As you will see, I'm not intending to create something new, but rather to highlight some perspective in phenomenology, some vantage point of phenomenological psychopathology, which can be very useful as I understand. And to make it more comprehensive for you, I will try to show some examples, and along with the examples, to think of some clinical consequences with you. And after that, I think we can discuss the thesis here presented. First, the context. Look, if I was honored by Professor Francesca Brenchen to open the year of conferences in PhenoLab, say 10 years ago, or even 5 years ago, I would not be able to make this exactly talk. And this is because, as you know, very, very, very recently, there is a growing call for changing paradigm in mental health. Changing paradigms in mental health is a very, maybe it's as old as mental health, but depending on the period of history, this call is weaker or the calls are louder as they are today. So the perspective which is necessary to focus today is this idea, which is presented as an example by this editorial of the Lancet Psychiatry, but I could present as well the report of World Mental Health Organization from August last year, 2022, both claiming for shifting the paradigm, both claiming for new perspectives to overcome some deadlocks in mental health. I don't think I need here to stress the deadlocks, though we can discuss it later, but all of us know that regardless of decades of billions of dollars of investment in this model, neuroscientific model, an important note, the neuroscientific model as the mainstream model for all mental health. This is my criticism against, not neuroscience, not at all neuroscience. After this three or more decades of high investments in this model, the results for public health are very disappointing in several perspectives. Bear in mind this disappointment. The contemporary context is just like asking for new paradigms. But searching for paradigms is not as easy as one may understand or dream of. And we have to look historically for paradigms to fill this gap. And it is in this context of new horizons or new desire for perspectives that we can find the introduction of this new, what I will call here, this new wave I call it the third wave of phenomenological psychopathology in the history of mental health. And we can summarize the ideas of reintroducing phenomenology for the third time in mental health history by this editorial in 2021, also in the Lancet Psychiatry, which asks in this yellow highlighted sentence if phenomenology might provide a way out of other deadlocks for psychiatry and psychology. This is our challenge here. This is the current challenge for phenomenology, not only for phenomenology, but also for the future of phenomenology as a relevant intellectual perspective in mental health. Well, this is a rhetorical question in the editorial of the Lancet, to which I would be Fulford, Professor Fulford from Values-Based Center in Oxford, responded with this short letter for the editorial, short comment, proposing that, yes, we can think of phenomenology as a relevant player for 21st century psychiatry and mental health as a whole, but if you are able to address subtopics, if you are able to highlight some perspectives of phenomenology which so far have, this is my thesis here, not developed as it should be. The main idea of this refocuses of phenomenology for 21st century psychiatry is the idea of dialectics. That's why the title of my presentation, Dialectics and Phenomenological Psychopathology. Again, just to highlight, I will not address this subject from a philosophical perspective. It is not my field, but within the field of phenomenological psychopathology. In other words, this empirical discipline, which has been developing since 100 years ago in order to understand mental disorders or mental conditions. Well, historically, and this is very important, I think this could be shared with all phenomenological psychopathologists. If we look behind, if you look under a historical vantage point, we can see that there are two perspectives, two main ways of performing phenomenological psychopathology, which I called in this paper, only for using simple words, fixed essentialism against the idea which I will develop here of dialectical essentialism. Forget a little bit about the essentialism, and you can understand that phenomenology, psychopathological phenomenology, is asked, or better, responded to classical demand in psychiatry regarding diagnosis. In other words, diagnosis was the main topic responding to which phenomenology got into the history of mental health, understanding under a deeper perspective what is, for instance, to be a schizophrenic person, bipolar person, and so on. So the classical texts in phenomenology, in phenomenological psychopathology, as well as the most recent ones, could be understood as pertaining to this fixed essentialism, that is, trying to better understand what is the essence of mental disorder. This is the mainstream, so to speak, of phenomenological psychopathology. On the other hand, we can see historically a perspective which is a minority in terms of history of phenomenological psychopathology, which I will call here dialectical essentialism, which, of course, like the fixed one, is interested in better understanding, in describing the structures of lived experiences, of altered lived experiences. But instead of searching for an essence of what is, search for some sort of dialectics, which I will put forward here. So from now on, we're gonna sort of forget the mainstream perspective in phenomenological psychopathology, and present some very short history of dialectics in phenomenological psychopathology. It's a short history because I don't have much time for it, but it is also a short history at all. Though some forerunners of it are very relevant, as we can see in this first citation. Well, in phenomenological psychopathology, this is a citation of phenomenological psychopathology, of general psychopathology, or Jasper's general psychopathology. We can find not many citations, not many uses, so to speak, of dialectics, though they are always understood as a relevant concept. Dialectics is the form of the movement, for instance, and even in general psychopathology, there's a short chapter on some dialectical comprehension of mostly schizophrenia. But what is of interest for us here is this quotation. Dialectics is the form, I should have stressed the form as well, in which basic aspect of meaningful connections become accessible to us. Namely, that these connections are not a simple sequence of events, but show a constant reciprocity. This is my emphasis. This is very Jaspersian, the idea that understanding something is understanding a dialectical relationship between parts and the whole. But particularly in this citation, we can see how dialects for Jaspers is not only a form, but is a form, a comprehension of a form, of a gestalt, which enable us to see the reciprocity of diverse experiences. That is, again, I mentioned, I'm putting words in Jasper's now, but if you kindly allow me this, but Jasper's is enabling us for seeing dialectics, movement and form and gestalt at the same time. And this is definitely very, very important for our contemporary needs, and should have been very important for the history of phenomenology, but it did not happen. Well, though there's some mentions in general psychopathology, the idea of dialectics was not a very champion idea in general psychopathology. So generally, we say that the first mention of something, that the first forerunner of the one day to be dialectics in contemporary phenomenological psychopathology is this book that I know you know very well, Three Forms of Missglückten Daseins, Failed Existence. In particular, the first one, just published first time in 1949, the idea of extravagance, of one of the possible translations for Verstiegenheit, in which Ludwig Binswanger introduced the idea at the very beginning of the text of an anthropological disproportion. Okay, this idea of anthropological disproportion in Binswanger's triforms is an inaugural idea, but he understood this perspective not under a dialectical perspective, but instead under static perspective and a static spatial perspective the idea of anthropological disproportion in schizophrenic persons. As far as I understand, the real moment in which definitely dialectic got into the history of phenomenological psychopathology is this 1972 in German, 1982 in English paper and chapter called Dialectical Conception of Anthropological Proportions. I think if you had a birth point of this contemporary notion of dialectic, I will put in this paper of Blankenburg. And look, this is 1972. 1972 is a moment of some turbulence in the history of Western countries. But we can understand that maybe at that moment, a more progressive political moment prompted some progressive responses in phenomenology as well. I should say that maybe the recent history, not very recent, but recent history of phenomenological psychopathology under the empire of neuroscientific model was so conservative one that even the responses of phenomenological psychopathology were also fixed ones, were also, so to speak, conservative ones. But this is a note. So this paper from 1972, along with this second one, what are the limits of dialectic approach in psychiatry, definitely introduce the idea of a dynamic perspective in phenomenological psychopathology. I chose a quotation just to offer as an example. Yes. From Blankenburg's Dialectical Conception, I quote, "From a static proportion, we have suddenly arrived at a dialectical relationship, the dialectical dynamics of elemental anthropological structures." He's clear in this point. Making dialectical phenomenology is somehow introducing the movement into phenomenological psychopathology. Now, if we introduce movement in phenomenological psychopathology, if we gave glasses, or better, if we offer eyes for the phenomenologist to grasp movement in the existence of the other, you can definitely have tools for seeing, understanding, and grasping existence as a movement. It's sort of tautological, but what is more problematic for me is that phenomenologists understand existence as development, as uncertainty, as possibility, but the phenomenological tool, the psychopathological tools for grasping it have been mostly fixed categories instead of moving ones. This is as if we are trying to capture a travel of, say, a train traveling with cameras, just taking pictures instead of making videos. If I can use this limited metaphor, I should say that the introduction of dialectics in phenomenological psychopathology corresponds to the introduction of a video maker in the history of capturing reality. So, a first summary of what dialectics can offer if taken to its ultimate consequences for clinical care. As I mentioned, allowing the introduction of psychic movement and the introduction enabling the grasping of transformation, as I will defend soon, in the field of psychopathology. So, my position is that only if we phenomenologists are able to see transformation, we can actually go beyond the strictly biomedical neuroscientific model. If we keep limited, stuck to the old fixed categories, we are not, or phenomenology as a whole will not be able to overcome, to go beyond the strict biomedical sense. I'll get back to that. And why? Well, mostly as Karl Jaspers foresaw, but did not develop, and Wolfgang Blankenburg developed more and sort of invited us all for developing, allows the description of dynamic interplays, both within and between dimensions of the subjective experience, which has been called historically a structural perspective in phenomenological psychopathology or structural phenomenology. Well, just checking my time here. So far, more general considerations, more general ideas. From now on, some applied use of these categories, of these perspectives. The main idea is, or the point I'd like to highlight and I defend, is that understanding dialectics in phenomenological psychopathology means diverging the gaze of the diagnosis in terms of diagnosing a situation from an experiences to a dialectics. That is, the diagnosis, the aim of the diagnosis are three. The aim of the diagnosis are the anthropological proportions. This is a classical Binswangerianian word. The simultaneously with diagnosing the characteristics of an ambiguity. This is a Blankenburg category, and Alfred Krauss, the German psychopathologist, as well, Alfred Krauss category. And thirdly, it is also diagnosing a dialectics between the experiences, which I call here position, which is the pre-reflective experience in its relationship with the attribution of the value which a person necessarily attributes to any experience, regardless of the psychotic or non-psychotic. So from now on, I will try to make some examples of the use of these three main dialectics for phenomenological psychopathology. I will use just one example because I was concerned with the time, but we can use more if we have time. And I also use some conceptions that I have developed, some other conceptions which are very classical ones. I'll try to differentiate them, and also some psychotic experiences and other non-psychotic experiences. This is purportedly for showing that this idea of dialectics in phenomenology is a general one, can use for all categories, for all experiences, regardless of the severity of the alterations. Well, I will take as the first example the borderline experiences. The name of borderline experiences, the official name of that currently has been borderline personality disorders. But as this is a talk in a phenomenological context, I would prefer to use something better. I use the idea that the dialectical essence of a borderline experience is a disproportion. In other words, understanding borderline experiences is understanding not the experiences per se, but the disproportion of the anthropological conditions of possibility which underlie these experiences. This is the core idea of phenomenological psychopathology, of understanding the conditions of possibility of, if you want, the form of the experience, instead of the symptoms of the experience. Experiences, understanding the form of experiences is understanding simultaneously some perspectives in relationship to each other. I will highlight two here, which are of utmost importance for my understanding of borderline disproportion, at least. The first one is the idea of intersubjectivity. Well, my point here is that if not all, many and the most important experiences in borderline persons has as its origin in terms of form the lack of relevance of the what I call self-pole, that is the experience of self, against the relevance of the experience of the other. In other words, a borderline person tries to kill themselves or cannot find any experience of happiness, say, or even had dissociative experiences, because we can understand, because they are too weak, so to speak, in front of, against a very relevant person. We can see that for understanding borderline disproportion, we can see an other, generally a relevant other, which is a sort of a center of the experience of the person. So the person gravitates around a center, which is a particular other. That's why, for instance, that we can understand the second dimension, which I will highlight here, the dimension of time, temporality. That's why the particular experience, particular affective experiences of borderline persons is so irregular, to such an extent that sometimes this person are misdiagnosed as bipolar disease, which has nothing to do. They are misdiagnosed because of the uneasiness of their affective experiences. My point here is that understanding the lack of stability, lack of affective stability of borderline persons are derived from this lack of strength in the relationship to a relevant other. If I feel myself, if I am more than feeling, if I am weak, if I live as an appendix of a relevant other, which is, for my eyes, too strong, my stability depends on their stability, his or her stability, usually parents or some other relevant marital person. So we see the lack of stability of the I of the borderline person because the other can change all time. If I am happy or I am stable only if I feel that I'm relevant to this other. If I feel that I'm not relevant to this other, I lack all of my stability. I get absolutely vulnerable and I can feel that life is senseless and can try to kill myself. This is the daily life of borderline persons. And I could use, and I even should use more dimensions, but I think it's enough for this moment of the talk. What are the clinical consequences? Why am I highlighting these ideas? Because after working 30 years as a clinical psychiatrist, I think that treating someone with borderline disproportion, someone with a borderline personality, does not have to do with, or is not possible actually. We can't help this person trying to make them have a full independence of this two relevant other. The main clinical consequence of this understanding is that we as clinical persons, we need to help the borderline person to manage the relationship with this other, but we must know that very frequently we have to use also, we have to contact, we have to introduce in the treatment this relevant other so that we can make some stability for borderline persons. So instead, this is my point, instead of imagining a psychotherapy of borderline as a psychotherapy of, say, an unreal independence, the clinical care of borderline persons is more a sort of mediation between a relationship, mediation between a weak person and a too strong person. It might look some a polemic statement saying what I've just said, but I can defend this idea because I can see this is the only way in which we can find the experience of less vulnerability and more stability for this person. So instead of searching for clinical control in terms of symptoms, or even instead of searching for full independence, the idea is trying to managing a sort of dependence which cannot be overcome. This will be a consequence of understanding the borderline disproportion in terms of excess of the other instead of symptoms, or and lack of stability of time instead of pure fluctuations of affectivity, as it is understood in this classical description of this personality. Well, I will use another very, very classical topic in phenomenological psychopathology, the idea of melancholic personality, which in classical times, since Telebach, has been called typus melancholicus, the idea of a person which has a lack of proportion between personal creativity and the social role. If you believe in Tellenbach, and I believe in his conclusions, a melancholic personality is someone which lives too much identified. Is a person who is too much identified with the social role. And so it's a sort of absorption of the social role, identification of the full person to the social role. As you know, as clinicians, it's not rare, there's this sort of melancholic personality developed a particular sort of depression, which is called melancholic depression, and also should be called only melancholy. I think we could even suppress the use of melancholic depression, as I was told yesterday for a patient. Why calling this depression? This is not depression. She said in Portuguese, I have a nothing in my head and an anguish in my chest. Why is this depression? Maybe she's right. So anyway, again, we treat this person. They have problems. We have to treat them as depression. We can use pharmacological treatments, psychotherapy treatments, but what is the main clinical consequence of understanding from the ambiguity perspective of melancholic personality? If we understand ambiguity, we can see that for the same reason, the same anthropological reason, for same condition of possibility, for the same reason, which is the source of experiencing of suffering, is the source of life of this person. In the case of melancholic personality, usually these persons are not available for changing themselves too much, because if they know, while they know that on the one hand, they have some sort of loss of creativity, of personal creativity, on the other hand, this way of being is their source of high reliability, high social reliability, or even they are responsible for the unity of their families, of their companies, of their peers, and so on. So they feel that this way of being, though sometimes painful, are their main asset for living. The clinical consequence of taking seriously the notion of ambiguity is that we should not try to transform the main characteristics of a person. Rather, we should aim at understanding in the very core of ambiguity the guidelines for helping them. In terms of melancholic personality, that means trying to bring forth after recovering from the more severe depressive experiences, of course, after that, in terms of psychotherapy, of recovery period, phase of a treatment, is trying to bring forth the experience of reliability which they have, instead of saying to them, don't be so concerned with your family, so don't be so concerned with your husband or wife. This usually does not work. At least I've tried for decades and does not work. On the other hand, trying to use this other side of ambiguity as an instrument for recovery seems to be a very fertile field. This is the same for borderline as the previous example. The borderline experience, on the one hand, brings pain, brings suffering, brings instability. On the other, brings passion, brings color for the life. Living with, as a patient of mine said once, his wife was a borderline person, very severe borderline. Doctor, after all, I think she's still worthwhile. The pros are still more important than the cons. So I'm staying with her. This is a very moving lesson I have for understanding the ambiguity of borderline personalities. The third one, the idea of the dialectics between values and a position of the experience, is a more in the order of the day. Is a hot topic today in mental health. And it is a hot topic in current mental health because, as you know, the new understanding of mental health includes the lived experience people, the people who had the experiences of mental disorders, and tries to, by this contribution, co-work with the patients for creating a strategy for their treatments or for their recoveries. Now, creating a strategy, co-creating a strategy is adopting, is listening to and adopting the values the patients attribute to their experiences. So the idea of highlighting and empowering the value attribution of patients is a very important idea today in the new trends of mental health. And this is a classical idea in phenomenology, also with roots in Carl Jasper's, not very developed roots, but roots in general psychopathology, and roots in more developed roots in 1949, Jacob Wirth's book, The Person of the Schizophrenic. Very important classical moments. What is of interest for here now is from the phenomenological perspective, there is no such thing as a pure psychosis. There is no such thing as a pure fracture of the constitution of experience. This is the definition of schizophrenia. But there is necessarily simultaneously two other movements, pre-reflective movements. One is the way the psychosis is incorporated pre-reflectively in the experience of the person, as, for instance, the person may understand it as a delusion, may understand it as a new gift, may understand it as an incomprehensible, bizarre experience, which usually assumes the face of a paranoia, and so on. So understanding schizophrenia is understanding the original break of the continuity of experience, along with the way this break is incorporated into the global experience of the consciousness, and a third dimension, which is more conscious one, the value attribution. In other words, what you understand out of what you've been living. The main clinical consequence, this is again the most researched clinical consequence today, is trying to, along with the patient, explain to them and listen to them about this value attribution. In other words, making a clinical care to someone with schizophrenia is, besides trying to limit or suppress the psychotic experience, which is rarely fully successful, also to develop, along with the patient, under a dialogical basis, under a co-productive series of strategies working on the value attribution of the person. What does it mean for you? What is the meaning of the experiences? And out of these experiences, trying to make the life of this person the best possible. I could use the idea of a value attribution as well for ambiguity in schizophrenia and other mental disorders, and as well for anthropological disproportion. All, and this is again, all alterations, all mental disorders can be seen from this perspective of anthropological disproportion, ambiguity, and the dialectics between the experience and the values attributed to it. Well, the main consequences I have mentioned then. I've given some very preliminary, and sorry for that, examples. But we could say in general that if you take in consideration this perspective, this dialectical perspective, I think we can shift the target of psychopharmacology. This is a topic of my interest, my particular interest, as I am a clinical psychiatrist. I think psychopharmacology is too important for being guided for this current mainstream model. I think it's urgent to shift the target instead of shifting or aiming symptoms, or instead of aiming suppressing diseases. The aim should be new proportions of the anthropological proportions. I cannot give examples here, but anyway, I like only to highlight the idea that we can, through this dialectical perspective, shift the target of psychopharmacology in mental health. And also, bear in mind what I've just summarized, understand psychotherapy as more than an understanding, though it is also a self-understanding, but also trying to address some pre-reflective targets, like, say, the time, temporality, like intersubjective, and so on. In short, I think dialectical phenomenology can really offer some relevant, can supply some very relevant tools for renewing psychiatry and mental health in the 21st century. But if you ask, just for concluding, is it guaranteed that phenomenological psychopathology is a tool, a sufficient tool for a new paradigm for this so desired new paradigm in mental health? I should say that I am optimistic, though in minor key. I think we can, phenomenology can, but to do that, we need more than only being a peripheral layer, some instrument for helping the main paradigm. I think that for phenomenology, indeed offer some impact in mental health. We need to understand phenomenology from this dialectical, from this global, from this existential and complex understanding of mental health, and transform, this is the main challenge, and transforming it in something understandable, understandable by the society, and trainable for not only the current phenomenologists, but for the new generations of phenomenologists and mental health. Thank you very much, all. Thank you very much, Francesca. I think I'm in time, or kind of.